welcome to Medlive Indian Perspective Expert Opinion. Today we are at CSICON 2019 being conducted at Ashok Hotel, New Delhi. We have Dr. Mrigonka Chaliha with us and Dr. Muruganathan with us, and we all are here to discuss on lipid management. So sir, you have delivered a session on new insights of HDL. So I would like to ask that lowering HDL or increasing HDL, how this will affect atherogenesis or formation of reactive oxygen species in all the process, AGE.
So the effort is on to lower LDL cholesterol and to increase HDL cholesterol. In this case, for the last few decades, statins have played a very significant role. It is a wonder drug. The statin has come and it has reduced LDL cholesterol, which is considered to be one of the most important cardiovascular disease risks. And also, it increases the HDL cholesterol level. But the question is to be seen whether in most of the studies that elevation, in raising HDL cholesterol level has not translated into cardiovascular benefit. So basically, we have to not only we have to numerically improve HDL cholesterol, but at the same time there should be improvement in the functionality of HDL cholesterol. There are some studies with niacin and CETP inhibitors, but we have to see what is the effect of statins on HDL functionality besides its role of numerically improving the HDL cholesterol.
Okay. So, what is your opinion on this?
Actually, AG, advanced glycation end products, is the molecule now we are focusing more because that affects the HDL. HDL has got a protective effect in atherogenesis.
Right.
So, when glycated HDL loses its potency and loses its preventive capacity. On the contrary, glycated LDL makes more problems for managing atherosclerosis. For example, glycated LDL makes the receptor is blocked, so more of a circulating LDL is more.
Right.
And also glycated LDL causes foam cells, and also glycated LDL produces some thrombogenic reactions.
Right.
So also the glycated platelets also makes it more adhesives in the vessel wall, and there are so many reactions. And reactive ROS is main thing, culprit. Oxidative stress is main culprit. So the statins has a role in managing to certain extent, because there are not studies, because many trials have come, but unfortunately not a effective drug to reduce the AGE. The statins reduce, or statins useful in AGE in one form. There is a age, advanced glycation end products, and that goes and attaches to the receptor. It's called RAGE. This RAGE and age axis signals lots of cascades and produces a lot of problems. And there is what is known as sRAGE. It is a truncated protein which is soluble and which is good, competes with the RAGE and goes and attaches to the sites. So sRAGE is a beneficial. This statin, there is some one study that it probably acts on age axis and improves the level of sRAGE. That way statin is very effective in the age.
Great, sir. So I would like to ask, by reducing AGE or by improving HDL, or is there any hypothesis or is there any data that together combining both of these, AGE and HDL, these may lower the LDL in atherogenic patients?
No, I don't think there is any study combining these two endpoints, that increasing HDL. I had already told that there is some disappointment or pessimism about raising HDL. So that is not a, but as a whenever using statins, definitely we are also increasing the HDL level.
Right.
So we have to see whether at a certain level of when LDL cholesterol is under control, whether additional benefit can be accrued by raising HDL. And
Okay.
whether there is any, also at that time, whether there is any improvement in terms of what Sir has already told about advanced glycation end products. So we can think in these terms.
Great.
Actually, the increased, I mean, the level of HDL, even if it is increased, there are no studies which will say that because of more HDL, you can protect atherosclerosis. But one thing is very sure, the number is important, but also the quality, the functional aspect of HDL is also important.
Yes.
The glycation causes HDL, glycated HDL loses its protective effect. At the same time, glycated LDL has more causing problems. And in fact, they say when you do glycated protein in atherogenic plaque, it makes the stable plaque to rupture more, rupture prone. And even in the atherosclerotic area, the glycated proteins are more. So we have to concentrate how to reduce this AGE with the drugs. And coming to the LDL, LDL is notorious, as he said. Now the recent guidelines say you have to reduce LDL, especially in a high risk group, even below to 50 milligram. See, we were talking about in those days 100, then we came to 70. Now the recent thinking is you have to reduce LDL up to 50. So
Yes.
in that case, when you want to reduce LDL very vigorously, so you should have intense treatment with statins.
Right.
So in all the problems, risky cases, we also give high intensity statins to reduce LDL. If there is no improvement and if you don't get desired level of LDL, we also add STMB with statin to make sure in high risk patients the LDL comes down to 50 so that you will have safe.
Great.
What is your
Yes, it's exactly what Sir is talking about is HDL has got the first point which he highlighted. When it is functional, HDL is very good. But when it becomes dysfunctional, when it is functional, it is anti-inflammatory, it is anti-thrombotic, it is endothelial, pro-endothelial functional. But when it becomes dysfunctional in situations like diabetes or metabolic syndrome,
Right.
it becomes pro-inflammatory. The good thing becomes bad. So
Right.
we have to protect that. That is one. And second important thing is most of the guidelines, the European guidelines or the American guidelines now are talking about in very high risk population. Very high risk population, the population with CAD or with other end organ domain. In those populations, we have to target HDL to below 55 or
Right.
50.
Right.
Even the Indian guidelines also talk about that.
And one more thing, there is one apoprotein A4. Apoprotein A4 is supposed to be good for protection of atherosclerosis.
Right.
When there is a glycation, this glycated apoprotein A4 through the nuclear receptor enzyme NR-A443 produces inflammatory reaction. They found out, Dice and al. Found out in the ApoE mice that there is a role of glycolylated ApoE4A. The interesting point about ApoE4A is, that is secreted by small intestines and goes into chylomicrons. And this apoprotein A4, even without the help of apoprotein, other apoproteins, this per se can be helpful in preventing atherosclerosis. What this glycation does is it also glycates ApoE4A4 and that produces more problem for atherogenesis. This is a new concept.
Great, sir. So it was really a very wonderful and valuable discussion on the management of lipids. So I thank you both of you. Thank you very much.